and cardiologists and doctors are less keen for their patients to come off those anticoagulants, because if they have an adverse episode while they're off them, then that indicates them in terms of potential, malpractice or whatever. And so that then puts it back onto surgeons and dentists that, we're going to be taking teeth out or operating on people who are on warfarin, heparin or aspirin or other anticoagulants where their doctors don't want them to come off. So we're going to expect that there's going to be more bleeding, there's going to be more bruising, and there's a potential, for more complications with that. So we're in a very difficult time frame with all of that, where, some physicians and cardiologists aren't happy for the patients to come off their anticoagulants. Diabetes is interesting, and again, if we have an uncontrolled diabetic, then we shouldn't be operating on them, and they need to be in a controlled situation. Okay, so there's issues with, systemic issues with the uncontrolled diabetes, but there's also local factors, increased risk of infection, poor healing. All of those things are relevant, and so there's a few papers here giving some information on diabetes. Certainly, if you have risk factors like diabetes, and then you add in another risk factor like smoking, that compounds it. So that really gets me concerned if someone's diabetic and they're a smoker, because the tissues are not going to heal well. The bone's not going to heal well, the implant's going to have potential trouble with integration, and the soft tissue healing in particular is going to be very poor, and you'll often see wound dehiscence with patients like that. And if they're a smoker and their diabetes is not well controlled, then that gives you some indication that they're probably not going to be good at following instructions on your post-operative instructions and all those sorts of things. So those things all married together all lead to being warning signs for us in terms of treatment. So autoimmune diseases. So there's been reported a higher failure rate with Crohn's disease. Systemic steroid therapy. So, and this is an issue with bone healing and bone issues. And then there's a small rate of high rate of failure rate that Moy found in his paper. So there are issues with systemic steroid therapy. Certainly, if patients are having chemotherapy or other treatments like that, then we wouldn't consider treating them until they're stabilized as well. Osteoporosis is an interesting one. So Freiberg reported on this with very good success rates, up around 97% for the maxilla and 97.3% for the mandible. So we can still treat patients with osteoporosis, but then there's some modified treatment. So Freiberg will often do a two-stage procedure rather than single-stage surgery, and leave the healing, an extended healing period for this, so we get a chance for better osseointegration, and then we'll have a modified surgical protocol. And whenever we place implants, we should be considering a modified surgical protocol. So if we've got very dense bone, we might be using dense bone drills and a screw tap. If we've got very poorly dense bone, then we might reduce the preparation size. We might not prepare to the full depth with all the drilling procedures. We wouldn't tap, these sorts of things. So what we see and what we feel with our initial drilling protocol, we may modify that protocol depending on our bone density and bone quality that we have, and then make an assessment. So not everybody's the same, and we've got to alter that, and that's what I said. When people come in, we'll be able to do quick and fast treatment options for some patients, and we may have extended treatment options for others, and they may question us about that as well. So it's important to individualize the treatment for each individual patient, and then we'll have less problems with our treatment. Osteoporosis, and again we'll see people who are on bisphosphonates or Prolia or some of these other treatments. So having osteoporosis for the spine and the long bones is a significant problem for some patients, and if you have elderly patients who fracture their hips or whatever, that can be often a terminal event for them in terms of getting them mobilized, and then they tend to go downhill fairly quickly. So it's not just a simple thing of saying we'd like to put implants into these patients and therefore we'll just get them to come off their bisphosphonates. That must be communicated with their physician or their doctor, and it may be that there's a significant risk for them to come off their bisphosphonate medication, and it might be better for them to have an edentulous space or have some other form of treatment rather than implants for that. So what happens with bisphosphonates? What it does is it affects osteoclasts, so inhibits osteoclastic activity. So what happens is then you get osteoblasts laying down bones, so we get increased bone density from that. That's not a problem for the long bones in the spine, but we've got a high bone turnover in the jaws, and so that's a problem. So bone is laid down at the expense of the blood vessels, and then you get a very dense bone, so most of your blood supply comes from the periosteum. You go then and extract a tooth or raise the periosteum to place an implant, and in some cases that there's not enough blood supply for healing, and that's when they go on to have necrosis and ongoing problems. So there's just a few of the early bisphosphonates that were used, and there's a myriad of new drugs coming out all the time. Very difficult to keep up with all of that. Again, and I've got osteoporosis and they give you their medications. I'll Google those just to see exactly what they're on. We can manage things, so with communication with their doctors, it may be that they can have what they call a drug holiday, or come off the bisphosphonates for a 3-month period, and then they'll have some recovery of their osteoclastic activity and get some better bone turnover, and we can then treat them safely. But I always warn them that even with this, there's a potential that they could have a problem. And it's not much fun for the patient if you've got an area, of osteonecrosis in the jaws. That can be quite painful. It's difficult to manage. You can't debride that. It just makes the area bigger. So we're really managing these sort of situations conservatively with chlorhexidine, maybe just some simple debridement of sharp bits of bone to make it more comfortable for them. So it's not a lot of fun having that for the patient. So we need to try and avoid those situations as much as possible. And so things that can cause the osteonecrosis, obviously extraction, implant treatment, but just simple denture wearing, where there's a sore spot under the denture, wears through the mucosa, exposes the bone, and then there's no blood supply to that overlying bone, and they go on to have problems. And this can last, years, months to years, in terms of having exposed areas, bones in the mouth, which is quite tricky. So there's a difference in terms of that too, the recovery if we come off the drug, if we've got bisphosphonates versus Prolia or whatever. So we need to understand what drug they're on, and then how long they need to be off that drug to reduce the risk of necrosis if we're going to treat them. So Marx's work, Marx in Florida, he did quite some of the early work on this, where they looked at patients with ONJ, and then they also noted that there was a higher incidence of the problem when the patient was also taking steroids and methotrexate. Methotrexate particularly interferes with tissue healing. And then there's the CTX test that has been available in South Australia. It wasn't available here for a long time. I'm not sure whether it is at the moment. It wasn't covered under Medicare, and so therefore they were very reluctant to provide this test in Perth. But there were some guidelines, and these are guidelines only. So with the CTX test, if your bone metabolism was less than 100 PGA, then you're a high risk, 100 to 150 moderate risk, and over 150 there was minimal risk. So the CTX wasn't definitive, but gave some indication of whether it was reasonable to treat the patient or not. So, and what Marx's work then said, with the CTX and a drug holiday, for 6 months, on oral bisphosphonates, there's a difference in with patients taking intravenous bisphosphonates. So the complication rate on someone taking intravenous bisphosphonates and osteonecrosis was up around 10%, and somewhere about 2% for oral bisphosphonates. So really there is not anything definitive at the moment with regard to treating patients who are on bisphosphonates. Certainly we try to hold on to the teeth as much as possible, so root fill them, keep them as long as possible, decoronate them, leave healthy roots there if possible, and only extract teeth if we really have to, and then warn the patients that there may be some issues with that. So this is a Prolia. So this is a fully human monoclonal antibody, and it affects the pre-osteoclasts, and the half-life of 25 to 29 days. So this has a more rapid resolution with the drug holiday. So therefore, the patient needs to be off this drug for less time than they would do for a bisphosphonate. And you see quite a few patients on Prolia these days. Periodontal disease is an issue. Certainly, we don't want to put implants into active periodontally involved patients, and you do see this in this city too. That can be a problem. And so the periodontal treatment needs to be carried out first. They need to be able to comply with that treatment before we would consider that. And then again, we've got smoking is related to that. Diabetes, so if you see someone with periodontal disease and they're a smoker and they're diabetic, there's significant warning signs with that in terms of treatment. Smoking, there's variable reports in the literature about smoking, but certainly that decreases the oxygen tension within the tissues. That affects both bone and soft tissue healing. And again, in a smoker with a 20 plus a day, when you operate on them, you'll often see very poor healing in the incision lines, dehiscence of the incision lines, and all those sorts of things. And smokers are notoriously not reliable. And so certainly if I'm doing some bone grafting, I don't want patients to smoke. If we're putting implants in the maxilla, I'm not really thrilled with that either. A bit of smoking and implants in the mandible doesn't seem to be as problematic. But if you've asked them to come off the cigarettes before treatment, like if you're going to do significant bone grafting, for example, they'll often come in and say they've been off for 3 months and they haven't, but you can smell smoke on their breath. So I really, very, very careful with this. And certainly afterwards, if they say they're going to be compliant beforehand, and they're generally not compliant afterwards. So smoking is, I think, a very big issue in terms of any kind of surgery, and particularly when we're considering implant surgery. If we look at smoking and machine surface implants versus tyenide implants, there's certainly less failure rates with the roughened surface implants than we see with machine surface implants. So that's well documented in the literature. But in this country, I think everybody's using surfaced implants like tyenide now rather than machined surface implants. So then once we've covered all of that and we've had a look at the medical history and decide that we're going to go ahead and put some implants into someone, we want to look at the smile line. If they've got a massive smile, then there's a high aesthetic demand for that patient. You can see everything, they can see it, you can see it, everybody can see when they smile, if they've lost dentate papillae, if they've got a different height in the gingival tissue between one case and the next. So if we just look at some of these cases, so in the first case, there's not low smile line, not so aesthetic demanding. And this one where they show all the gingival tissues, high aesthetic demand. Even with someone with a low lip line, if they're concerned about, they might lift their lip up and look at the tissues and be very unhappy. So you can't just assume that the person who's got a low lip level is going to be happy with a result that's not level or even. So we've got to have adequate space for implants between teeth, and I mentioned that before. Particularly the issue of missing lateral incisors can be a big problem. So we need to have some assessment of the adjacent teeth, and then whether or not it's possible to treat that. Nothing worse than placing an implant there and damaging the adjacent tooth roots, and the patient goes on to have problems with the adjacent teeth. And then there's important structures. So when in the anterior maxilla, when we're replacing a central incisor tooth, for example, we've got the nasopalatine canal there. And one of the early problems with failures of implants in those sites was winding up the tissue within the nasopalatine canal and compromising osseointegration. So we need to make an assessment of those canals. They're variable in size, some are small, some are big. And again, if they've lost bone, there's a temptation to place the implants closer to those canals, so we need to make an assessment. And obviously, in the mandible, we've got important structures, the mental nerve, the infraalveolar nerve, and we need to be conscious of those. And so, good assessment. And I would consider that, the standard of care these days would, if you're putting an implant in over the nerve, then we would need a CT scan or a cone beam scan, or OPG, or periapical films is not adequate in terms of making a proper assessment for implants in those sites. Informed consent is, and I touched on this earlier when taking out teeth, so we have to have informed consent. So all my patients sign a consent form. I never do any treatment on anybody unless there's been a consent form signed and they understand, and I give them the opportunity to ask questions about the treatment that they're having done. So, just a list of simple things, to look at. We need to look at undercuts. If somebody's got a class 2, division 2 malocclusion where their upper incisors are fairly upright, that means that the roots are going to be placed labally. There's going to be very thin bone over those roots. And when you go to place an implant in a situation like that, if you don't make a good assessment of that, you can have a situation where the implant's in the bone and the ridge, but the implant's sitting in the soft tissues towards the apex. So very difficult problem to sort out then. So often in those cases we might need to have grafted some bone labally so we have the apex of the implant in there. But if we use a new Noble Biocare screw channel system, which Sam was going to speak about tonight, but just easier. So we have some options which I'll show later where in those situations we can place the implant in the bone and we can still have a screw retained result by using the ASC system. So we must have some sort of protocol to follow. So if we have this and then we follow our protocols, then we're less likely to have mistakes. So we might decide we need study casts and a diagnostic workup. We need a radiographic template. If we're going to do a scan, we might as well have a template in the scan giving us some more information about that. And then we have surgical protocols to follow. So that's important. And really, probably most of the time when we're looking at doing implants today, we're probably looking at getting a cone beam is the easiest thing to get to make assessments of bone volume. Even in the anterior arch, you see a case where it might have very thick biotype, and I've seen this where it looks as though you've got a very bulky wide ridge. You open up the tissues and it's a knife edge ridge. So you don't want to be caught out with that. And so we're lucky in this country that we've got easy access, to those sorts of scanning techniques, and patients are covered partly by Medicare as well, so it makes it much easier. So, aesthetic considerations, relative tooth position. The position of the free gingival margin, why is that important? Because we're going to place our implants in an appropriate position, and maybe 3 millimeters, 2 to 3 millimeters below the free gingival margin. The facial and lingual position, mesiodistal position. So have we got enough room between the adjacent tooth roots? Have we got enough bone, facially? And as I said, what we want to have on each side of our implant, on the facial surface and on the palatal surface in the maxilla, we want to have at least 2 millimeters of bone either side there. Otherwise we will get resorption and we will get gingival recession, and we may get problems with aesthetics or even abutment showing. So that's important. The form of the periodontium is important. If we've got a situation where it's very high, is it normal, is it flat, gingival scallop? So if it's very high, then we can say that there's more likely to be recession, and we might consider doing a connective tissue graft. If it's thick tissue, well, less recession, as I said. If it's thin tissue, then there will get more recession. And the shape of the tooth is important. So if it's a square or ovoid or triangular shaped tooth, that's also going to affect the position of the gingival tissues, any shrinkage of the gingival tissues when we extract that tooth, and different protocols and different treatment considerations when we're going to replace a single tooth implant. So if we've got a thick biotype and square teeth, this is really nice. So if we have one of these central incisor teeth failing, then we can be pretty happy that we're probably not going to have to do too much in the way of the soft tissues. As long as we conserve the tissue that's there, we're probably going to end up with a good result. If we have this situation where we've got some pathology around this tooth and we've already got some gingival recession on this tooth, I already know if we're going to extract this tooth and put an implant there, I'm going to have to do something with the soft tissues because the soft tissues are already deficient. It can only get worse, and the patients don't like it when there's a difference in height between there. And we just need to look at the adjacent teeth and we can see the recession on the laterals, the recession on the canines, and that sort of thing. So we don't want to be blamed for more recession on there. We don't want to be blamed for a poor aesthetic outcome. So we need to know from the beginning that there's probably going to be maybe some hard and soft tissue augmentation required to get a very good result for that particular case. And again, just looking at a diastema between these teeth. So if we've got a diastema there and we're replacing that tooth, we've got to be realistic about tooth size. So we might say, okay, well, we can enlarge the tooth size there, have a long contact between those adjacent teeth, and that makes up for a shortened interdental papillae. But then if you've got two central incisor teeth at different sizes, that's not going to be too cool as far as the aesthetics go. So there's a bunch of things to consider, and maybe we have to say that when we're restoring a tooth like this, that we need to leave that diastema there to get a good aesthetic result. And so all of these things have got to be discussed beforehand. We don't want to do this and then them go, well, really I wanted that gap filled in as well, doctor. So we need to make a really good assessment and have a very good understanding of what the patients want. So I always ask them, what do you see as the problem and what do you want to see fixed? So I have that written down straight away so I know what they're thinking, and then I start having a think about what I can do and whether what they want's achievable or not in my hands. We may have some attachment loss. So if we see this situation where we've got a decent bony defect in here, when we extract this tooth, we know we're already behind. We've got some loss of bone here, so we're going to get shrinkage of that interdental papillae. We're going to have a deficiency in bone, so we're not going to be able to have good coverage of the implant. And if we've got bone deficiency, then we're going to have gingival tissue shrinkage and deficiency as well. So we need to address all these things. And what I found over the years is, patients may not have a good assessment of what their situation is now, but as soon as you've operated on them, they're looking every day in the mirror and they start seeing things that they thought weren't there before. For example, they might not think that they had loss of this interdental papillae. So we've got to point these things out with photographs and whatever else and have them look in the mouth and say, look, you're missing this tissue between your front teeth. We've got to replace one of these central incisors. Are you happy with that tissue missing there? You understand it's missing already. Are you happy about that? And then you say, well, I'm not happy about that. And you go, okay, nobody in the world can grow the interdental papillae, but maybe we can do a little bit of soft tissue grafting in that area, improve that a little bit. Maybe we can have a long contact between these teeth so it's not so big. And maybe we can have